Welcome to ACC's Guideline Updates. Episode G8, Pulmonary Embolism. I am Dr. Z, hospitalist attending, and KC is here with me. Educational only, not individual medical advice.
Dr. Z, I want to start with something I honestly did not know before this episode. There had never been a single AHA/ACC guideline for pulmonary embolism. I thought CHEST was the authoritative one.
CHEST, the European Society of Cardiology, ASH, ACC PE. They all had PE guidance, but they did not fully agree, and none of them was a unified American framework. The 2026 AHA/ACC PE guideline, published in February in Circulation and JCC, is the first. It is co-sponsored by 10 professional societies, and that list includes the Society of Hospital Medicine. Hospitalists were explicitly at the table.
That matters. Because honestly, PE is one of the diagnoses where I feel like I am making up my own synthesis of multiple conflicting sources every time.
Which is exactly the problem this guideline is designed to solve. And it does that through a new 5-category clinical classification system. This is the structural backbone of the whole guideline, so let's spend real time on it.
Walk me through it.
Category A, incidental or asymptomatic PE. Found on a CT done for another reason. Patient has no symptoms and no hemodynamic consequences. Category B, mildly symptomatic, hemodynamically stable, and low risk for short-term adverse outcomes based on scoring tools like PACI or simplified PACI, without significant right heart strain or troponin elevation. Categories A and B together form the low-risk group, and these are the patients where outpatient management becomes a real option.
And then it escalates from there.
Right? Category C, symptomatic PE with elevated risk for adverse outcomes, based on imaging findings, biomarkers like troponin or BNP, or clinical features showing right ventricular strain. These patients need hospitalization and monitoring, but they do not necessarily need advanced reperfusion. Category D, PE with hemodynamic compromise that is not immediately life-threatening. Borderline hypotension, worsening tachycardia, early signs of right heart failure. Category E, refractory hemodynamic instability or cardiac arrest from PE. D and E are where you need to move fast and call for help.
Let me test myself. A 45-year-old woman, shortness of breath for 2 days, heart rate 110, blood pressure 114/70, troponin mildly elevated, CT shows bilateral PE with right ventricular dilation. Where does she fall?
That is your classic Category C. Symptomatic, hemodynamically intact, but with evidence of right heart strain, elevated biomarker, concerning imaging. She needs inpatient admission, close monitoring, anticoagulation, and you should be asking, is she at risk of deteriorating into Category D? That is the key question with AC.
And that is where PERT comes in?
Exactly. PERT is the PE response team, a multidisciplinary group, typically including pulmonology, interventional cardiology or radiology, cardiac surgery, and hematology, depending on the institution. The 2026 guideline implicitly supports the PERT model without mandating it by name, because it emphasizes multidisciplinary decision-making for higher-risk categories. In real practice, a Category C patient with deteriorating hemodynamics is exactly who you call PERT on.
What does a PERT call actually look like from the hospitalist side?
You call early, before the patient is in crisis. You say, I have a submassive PE with right ventricular strain, troponin positive, and I am concerned about trajectory. The team converges, usually remotely at first, and you have a real-time conversation about whether this patient needs catheter-directed therapy, systemic thrombolysis, or can be safely managed with anticoagulation alone and close monitoring. The hospitalist's role is recognizing the signal and initiating that conversation before you are in a Category E scramble.
For D and E, what are the actual advanced therapy options?
3 main ones. Systemic thrombolysis, alteplase given intravenously, high efficacy for opening the clot, but significant bleeding risk, including intracranial hemorrhage in about 2% of patients. Reserved for Category E and carefully selected Category D who are rapidly deteriorating. Catheter-directed therapy, thrombolytics, or mechanical thrombectomy delivered directly into the pulmonary artery, lower dose and lower bleeding risk than systemic, used more broadly for Category D. Surgical embolectomy, open surgical clot removal, reserved for massive PE where other options fail or are contraindicated.
That explains why PERT matters. The hospitalist cannot make those calls alone.
And should not try to. The hospitalist's job is triage and early escalation. Let's talk about the other end of the spectrum, the low-risk patients, categories A and B.
This is the one that surprised me. The guideline actually supports sending PE patients home from the ED.
With the right criteria, PACI class 1 or 2, or a simplified PACI of 0. No right ventricular dysfunction on echo or CT. Troponin not significantly elevated. Hemodynamically stable. And critically, adequate home support and reliable access to follow up within 1 week. If all of those are true, the guideline supports ED discharge with a DOAC and close outpatient follow-up.
I was trained that PE always gets admitted. That is going to take some adjustment in my instincts.
The instinct was not wrong before 2026 because there was no guideline to support outpatient management confidently. Now, there is. What has not changed is the need for judgment. Social support, access to care, language barriers, prior bleeding history, all of those matter in deciding whether a given low-risk patient can safely go home. The guideline opens the door. The clinician still has to walk through it thoughtfully.
Anticoagulation choice. I want to make sure I have this right.
DOACs are first line for most patients. Rivaroxaban and apixaban can be started orally from day 1 with no parenteral bridging required. That matters for patients going home. Edoxaban and dabigatran require an initial course of parenteral anticoagulation before transitioning to the oral agent. For most patients without complicating factors, rivaroxaban or apixaban is the practical choice.
What are the situations where DOACs are off the table?
Pregnancy. DOACs are not recommended. Use low molecular weight heparin or unfractionated heparin. Mechanical heart valves, also no DOACs. Triple positive antiphospholipid antibody syndrome. This is one people miss. Rivaroxaban specifically has been shown to have worse outcomes than warfarin in triple positive APS. Use warfarin there. Active malignancy. Low molecular weight heparin has historically been preferred, though certain DOACs are now supported for cancer-associated VT depending on cancer type and bleeding risk. And IVC filters. The guideline is clear that these should only be placed for confirmed contraindication to anticoagulation, not as routine add-ons, not out of habit.
Anticoagulation duration. How do I decide at discharge whether this is 3 months or longer?
At the time of the index admission, most patients should be treated for at least 3 months regardless of provoked or unprovoked status. The 3-month visit is when you reassess. That reassessment includes, was this a provoked PE with a transient risk factor that is now resolved? Then 3 months may be sufficient. Was this unprovoked? Higher recurrence risk and extended anticoagulation beyond 3 months is strongly worth discussing. Active cancer, prior VT, or ongoing high-risk conditions generally favor indefinite anticoagulation. The hospitalist should document the framework in the discharge summary and make sure the 3-month appointment is not left to chance.
What goes in a good PE discharge summary by this guideline standard?
Minimum 4 things. 1. The category and the rationale. 2. The anticoagulant chosen and why, including any exceptions noted. 3. The 1-week follow-up appointment scheduled before the patient walks out, not just recommended. 4. A TEPH screening plan documented, meaning the outpatient provider knows to ask about persistent dyspnea at every visit for at least 1 year.
TEPH. I want to understand this better. What am I actually looking for at follow-up visits?
The red flag is dyspnea or exercise intolerance that does not resolve or keeps worsening after the acute PE period. Most patients feel better within weeks to a few months of treatment. If someone is still significantly limited at 3 months and beyond, TEPH has to be on the differential. The screening question is simple. How is your breathing compared to before the PE? Has it improved? Are you still short of breath walking upstairs? TEPH is treatable with surgical endarterectomy or medical therapy, depending on eligibility. The tragedy is that it is often diagnosed years late because nobody asked.
And the psychological piece. I saw that in the guideline and was surprised it made it in.
PE is a frightening event. Sudden dyspnea, fear of death, often no warning. Studies show rates of depression, anxiety, and PTSD in the months after PE that are comparable to other major acute illnesses. The guideline recommends screening for psychological health at follow-up visits. For most hospitalists, that means asking or making sure the primary care physician knows to ask and having a referral path for mental health support. It is not complex. It just requires us to remember it exists.
Give me the 3 take-homes I am carrying out of this episode.
1. Use the 5-category system at diagnosis. It tells you care setting, escalation threshold, and whether outpatient management is appropriate. Categories A and B can go home with criteria met. Category C stays, and you watch the trajectory. Categories D and E call PERT and move fast. 2. Anticoagulation is a DOAC for most patients. Rivaroxaban or apixaban if no contraindication. Know the 4 exceptions: APS, pregnancy, mechanical valves, and some cancer types. 3. The discharge document is part of the intervention. 1-week follow-up scheduled before discharge. 3-month visit for anticoagulation duration decision. TEPH screening documented as an ongoing responsibility for at least 1 year.
G8 done. And I feel like I actually have a framework now instead of a patchwork. Next is G9, GI bleeding.
2 ACG guidelines, 2 ends of the GI tract, and 1 transfusion threshold that most people still get wrong. See you in episode GE9 on AZENTS.